I'm Andreas Kalogeropoulos. I'm an assistant professor of medicine at Emory University School of Medicine in Atlanta, Georgia. And I will be presenting our work tomorrow at the International Academy of Cardiology annual scientific sessions. The title of our work is Adjudicated versus Administrative Heart Failure with Preserved Ejection Fraction. And our goal with this work was to estimate the prevalence and the outcomes of patients with heart failure and preserved ejection fraction, which is commonly nicknamed HFpEF, in an outpatient cardiology clinic. The motivation behind this work was the recent difficulties encountered in clinical trials in HFpEF. And for this purpose, we have individually reviewed 2,000 consecutive patients seen in the outpatient cardiology clinics at our institution, Emory Healthcare. And we classified those patients based on their presenting ejection fraction and also their track record in terms of left ventricular ejection fraction. What we found was that using a cutoff point of 40% to define reduced ejection fraction, 60% of outpatients in our cardiology clinic have heart failure with reduced ejection fraction, and the remaining 40% present with preserved ejection fraction. However, among these 40% of patients with preserved ejection fraction, half of them have a history of reduced ejection fraction in the past, which effectively means that these patients are what we call heart failure with recovered ejection fraction. So the overall prevalence of true HFpEF in these patients was a little bit over 20%. Most importantly, when we evaluated mortality and other outcomes in these patients, we observed that patients with recovered ejection fraction had significantly lower mortality rates over 3 years of follow-up. And similarly, the composite endpoints of death or hospitalization or cardiovascular hospitalization or heart failure-specific hospitalization, which are commonly used in clinical trials, were significantly lower in patients with recovered ejection fraction. In addition, we observed that patients with true HFpEF had lower rates of death or cardiovascular hospitalization and death or heart failure-related hospitalization, which are commonly used in heart failure clinical trials. And the same trends were observed when we looked at hospitalization rates in terms of cumulative hospitalizations over time. So in conclusions, in this study, we found that we cannot reasonably consider together patients with recovered and preserved ejection fraction because they have different trajectories. We also observed that patients with recovered ejection fraction have lower event rates than the other groups of patients, both HFpEF and HFrEF, and also that patients with HFpEF have lower event rates than previously thought, especially event rates of composite endpoints commonly used in clinical trials of HFpEF.